We at the Vanderbilt site was given 30 minutes to talk about sort of whatever we want to talk about. And we've gone over our clinical projects in detail before at different venues. And, you've seen some of those publications. We thought it would be good for us to highlight our scientific core, which is the phenotyping support core. It's led by Wei-Chi Wei, who is going to be our second speaker today. And our first speaker is Monika Grabowska. She completed her master's in biomedical informatics, and what she'll be talking about today is actually her master's thesis. She's currently a MD PhD student at Vanderbilt. She has, I believe, she's competed and successfully gained an F30 training grant, and so she's one of the rising stars. So Monika, go ahead and come on up here. She's going to talk about pediatric Phecodes for electronic health records phenotyping.
Good morning, everyone. Great. If I can get these slides up. Yep. The screen button. Okay. Okay. All right. Well, sorry for that technical delay, but with that, I'll be talking about our group's work developing pediatric Phecodes or PEDS Phecodes for better high throughput phenotyping of pediatric cohorts. Is there a button I press to progress the slides? Is it just the, okay. Thank you. Well, I do have some learning objectives up here just to meet the CME requirements, but I'll skip those. I believe these slides will be shared later if anyone wants to peruse them. But kind of as we've talked a lot about during the course of this meeting, EHR-based phenotyping is incredibly difficult. Electronic health records weren't developed with research use in mind, and accurately and reliably defining patients with a particular phenotype as well as appropriate controls remains a complex process. One of our lab's approaches has been Phecodes for high throughput electronic health records phenotyping. And so Phecodes are basically groupings of ICD-9-CM, ICD-10-CM, and ICD-10 codes into just under 2,000 kind of clinically meaningful and distinct phenotypes. So the benefit of the Phecodes is that they reduce that ICD code phenotype space from the tens of thousands of ICD codes into just under these 2,000 distinct phenotypes, enabling researchers to perform phenome-wide association studies or PheWAS analyses, which basically allow one to examine associations between genetic variants or other attributes and basically the phenotypic spectrum. It's also important, however, to recognize the limitations of the existing Phecodes and how they were developed and kind of acknowledge some of their limitations. So the existing Phecodes were developed primarily using population-based diagnoses from adult patients. And as such, they don't necessarily capture the unique pediatric spectrum of disease. As we know, pediatric patients experience different diseases and outcomes compared to adults. And that's something we've seen within our own EHR data at Vanderbilt. And so our goal with this work was to develop these specialized pediatric Phecodes that would enable us to more effectively phenotype pediatric patients using our EHR data. And so kind of to, first of all, evaluate the validity of our hypothesis, we mapped the ICD diagnoses we had within our EHR to existing Phecodes and looked at differences in prevalence between the pediatric populations, which we defined as less than 18 years of age, and then the adult populations. And we saw that there were marked disease differences with a lot of kind of infectious diseases as well as congenital anomalies with higher pediatric prevalence highlighted here in the top. And then, as you would expect, more kind of diseases associated with aging, more chronic illnesses that were enriched in the adult populations. But kind of, again, we decided we would want to modify and build off the existing Phecodes and adapt them for better use in pediatric populations to enable pediatric specific PheWAS analyses. And so for this, we kind of developed this hybrid data and knowledge-driven approach where we looked at kind of patient counts from our own EHR, and then kind of mapped them to the existing fee codes, evaluated the differences between the adult and pediatric patient populations, and then used that as our basis for kind of reviewing with our clinical team, who then provided recommendations about how we could better tailor the fee codes and kind of modify them for better use in pediatric populations so that they could reflect more effectively pediatric disease. But here, on the left-hand side, one part of this was just removing the existing fee codes that represented phenotypes that weren't especially relevant to pediatric populations. So for this, we looked specifically at those fee codes that had less than 50 pediatric patients, so a very low count of pediatric patients. And then our team of clinicians went through those with us and kind of provided recommendations about fee codes that represented phenotypes that could be effectively removed from our pediatric fee code set, as well as which fee codes we should keep. And the idea here was that we didn't want to remove kind of rare diseases that might just have low counts because they're infrequent in the population, but still affect pediatric patients. But kind of just removing, again, those aging-associated chronic illnesses that are unlikely to affect adult or unlikely to affect pediatric populations. And then here on the right-hand side, kind of the other process was specifically creating new fee codes reflecting kind of important pediatric phenotypes that might not have been captured in the original fee code set. So here specifically, we looked at kind of the patient counts mapped to each ICD code within a fee code, compared the distributions in the adult and pediatric patient populations, and then kind of went over those with our clinical team to kind of make new fee codes building off of those existing fee codes. And so kind of as you can see here, we ended up removing around 173 fee codes from the existing set, adding around 350 to give us a total of 2,051 pediatric fee codes. And kind of one example of how the pediatric fee codes are more effective for pediatric-based phenotyping is with kind of, for example, chromosomal anomalies and genetic disorders. You can see in the original fee code set, it's kind of just binned under one bucket, but we really were able to kind of add higher levels of granularity into that phenotype with our pediatric fee codes. And you can see now we have further kind of fee code buckets describing what specific chromosomal anomaly this is, whether that be Down syndrome, Edwards, Marfan syndrome. And beyond just creating the fee codes or the PEDS fee codes from the original fee codes, a second component was kind of validating that these pediatric fee codes were in fact more effective. And for this, we performed these comparative PheWAS replication analyses. So we extracted information on known pediatric genotype-phenotype associations from the GWAS catalog. We extracted a total of 687 of these known associations, and then evaluated the ability of the pediatric fee codes compared to the original fee codes in being able to replicate those associations. And we saw that the PEDS fee codes performed superiorly in those analyses, replicating significantly more, 248 versus 192 out of the 687 SNP phenotype associations, kind of demonstrating that these are more optimized for use in pediatric analyses. And then just to give an example of what these comparative PheWAS analyses looked like, we have some PheWAS Manhattan plots. This is for a SNP in the Rett gene, which according to the GWAS catalog was associated with Hirschsprung's disease. But as you can see, well, first I'll walk you through the Manhattan plot for those of you who aren't familiar, but basically on the x-axis, we have the fee codes, which represent phenotypes, and they're colored just by disease category. And then on the y-axis, we have the negative log 10 of the p-value for the association between the fee code and the genetic variants of the SNP, the variant in the Rett gene. And we can see in the top plot with the PEDS fee codes, we're able to kind of replicate that association between Hirschsprung's disease and the SNP, but we weren't able to pick up that signal with the original fee codes. And I think I'm missing the horizontal lines, but kind of originally there was a horizontal blue line at the bottom, just indicating the p equal to 0.05 replication threshold, and then a higher red line for the Bonferroni corrected p-value threshold. But again, kind of just this idea that we're able to pick up certain pediatric relevant associations only using the PEDS fee codes, but not the existing fee codes. And then here we have another example highlighting some of the advantages of the added granularity of the phenotypes that we added with the PEDS fee code set. So this is for a SNP, which is in the ASIC2 gene and had been associated with cardiac septal defects. And you can see in the top plot with the PEDS fee codes, we are able to pick up several more granular signals related to cardiac septal defects. We have common ventricle, we have some congenital anomalies of great vessels, we have atresia and stenosis of the aorta, we have PDAs. But with the fee codes, we kind of can only pick up one, congenital anomalies of the great vessels. And you might see that the signal looks a little bit shifted. It's the same signal, like the same congenital anomalies of great vessels comes up in both. We just ended up recategorizing some of the fee codes into different disease categories to better reflect organ systems. So, for example, some of the cardiac congenital anomaly related phenotypes moved from the congenital anomalies category to the cardiac or the circulatory system category. But again, kind of reflecting the unique advantages of the PEDS fee codes and kind of detecting these more pediatric relevant granular signals related to cardiac septal defects. We also looked at the ability of the PEDS fee codes to potentially detect novel SNP phenotype associations. And for this, we're looking at kind of those signals that we identified only in PheWAS using the PEDS fee codes, but not with the existing fee codes. And this time kind of using a Bonferroni corrected significance threshold versus our replication threshold of p equal to 0.05. And we saw around just under 350 kind of novel associations, which were not limited to the newly created fee codes, suggesting that these PEDS fee codes are picking up some kind of unique signals, which aren't just because we created new codes, although we're still kind of in the process of evaluating some of these. But that kind of sums us up in kind of how we developed and evaluated the PEDS fee codes. Some important limitations. Again, we built this based off ICD diagnoses that we had in our EHR at VUMC. We only used the GWAS catalog for identifying our pediatric genotype-phenotype associations for validation, which might present a source of selection bias. With ICD codes and with fee codes, we aren't necessarily able to capture rare diseases since a lot of rare diseases don't have ICD codes for them. And then kind of this final point, knowledge assembly is an iterative process. The fee code mapping has undergone a lot of revisions from the existing fee codes to the fee codes we have now, and the pediatric fee codes will likely follow suit. We always welcome emails. People will give us suggestions or questions. And as you hopefully start to use the fee codes in your own research, definitely reach out to us if you have any things to add. But kind of to sum us up, in this work, we have introduced PEDS fee codes as a high throughput electronic health records phenotyping tool specifically designed for use in pediatric populations. We developed these PEDS fee codes from the existing fee codes, which had been widely used in research, and then validated these fee codes using kind of genetic replication studies to look at kind of being able to replicate known pediatric genotype-phenotype associations. We did find that the pediatric fee codes were able to deliver superior outcomes in PheWAS compared to the fee codes for those pediatric genotype-phenotype associations. And then we hope that researchers will be able to use these to perform better large-scale kind of phenome, genomic, and genomic analyses in pediatric cohorts. We do have an R package available for those of you who've ever used the pediatric or the regular fee codes. Robert Carroll and his team from Vanderbilt had developed the PheWAS R package, but we have a PEDS PheWAS R package at this link here. And then you can also browse the PEDS fee codes and the fee codes at www.phecode.org. And we now have not only a mapping for the ICD codes to fee codes, but also a mapping for SNOMED codes. And then I'll acknowledge kind of all our collaborators and then our funding sources. Again, we got MPRINT support pool funding for this work, and we are very grateful for that. And I think we'll probably save questions for kind of after, but with that, I am done.